Welcome to Texas Heart Institute Innovative Technologies and Techniques. I'm Zvonimir Krajcer, an interventional cardiologist at Texas Heart Institute and Baylor St. Luke's Medical Center in Houston, Texas. I would like to share with you the latest advances in computational modeling and simulation for patients undergoing TAVR. I have no disclosures related to this presentation. So what is the utility of artificial intelligence in medical imaging? As we can see here, it has importance in diagnostic imaging, in segmentation, and anatomical landmark detection, and 3D reconstruction. And this has been published, as you have seen on the bottom of this slide, on numerous publications. But the latest advances are related to simulation and the use of artificial intelligence in the field of structural heart disease, particularly related to TAVR. So what is the traditional paradigm related to patients that undergo TAVR evaluation? For example, if we have a new TAVR candidate, typically we obtain information as far as patients' characteristics are concerned, such as age and comorbid conditions, and also obtain diagnostic imaging findings from CT and also coronary angiography. This is then analyzed by the operator and the team, and on the basis of their clinical experience and their preferences, the clinical decision is being made, and the outcomes depend on the physician and team's ability to integrate and make the right decision related to this particular patient. Now, the new generation paradigm is implementing the use of artificial intelligence and computational modeling. And the paradigm would look like this: a new patient with the information related to patient specifics and diagnostic imaging then is integrated into artificial intelligence and machine learning model, and then together with physicians driven computational model and clinical experience is used in three-dimensional visual model that we will see in the following slides. And then physician and a team makes the clinical decision that obviously leads to certain outcomes. What is the importance of this particular computational modeling and the use of artificial intelligence? Number one, it's highly accurate. It requires significantly less effort and time to train the model than to train the physician. And also, physician gets to preview device and also tissue interactions and avoid certain complications. There are also multiple scenarios possible that leverage physicians' knowledge and also simulate future scenarios and interventions where necessary. As far as computational modeling is concerned, it offers rapidly growing information as far as predictive power is concerned. It can also simulate all valve types, sizes, and configurations that can be used for TAVR. There's also multiple risk assessment capabilities, such as coronary obstruction risk, risk of aortic rupture, or need for a permanent pacemaker, or risk of perivalvular regurgitation, and finally, the risk of thrombosis, such as HALT or SLT, is concerned. It also offers us a lifelong planning and gives it an option to choose the best scenario for any particular patient with aortic stenosis. Now, this computational modeling and AI technology can be used for both balloon expandable valves and also for self-expandable valves, as we can see here in computational modeling. And this will be also available in the future for other valves that are currently not on the market. As far as DASI simulation validation is concerned, it uses a 30-day CT to validate the predictability of certain scenarios. Here is one of the patients that had a SAPIEN 29mm valve implanted, but due to severe calcification, as we can see in the annulus, the valve was underexpanded to 27 millimeters in diameter. And as we can see here, the 30-day post-TAVR CT well agrees with computational model showing above, and also shows the residual gradient on echocardiogram due to underexpanded balloon expandable valve. Now, one of the very important predictors with DASI simulation is predictor of coronary obstruction. And how is it calculated? The important parameters that are included in this particular algorithm is the distance between the leaflet to the coronary ostium and divided by the diameter of the coronary artery. As you can see here with the computational modeling and machine learning, that particular algorithm shows important information in predicting the risk of occlusion of the ostium of the coronary artery. What is shown here, if the DLC is less than 0.7, then there is a higher risk of coronary obstruction than if DLC is greater than 0.7, as shown on the right side graph is concerned as far as sensitivity and specificity is concerned. And this has been published by Heitkrempner and Associates in Journal of Thoracic Cardiovascular Surgery in 2020. Now, another important use of this particular computational model and simulation is in prediction of aortic root rupture. As we can see on the left-hand side, after deployment of the balloon expandable valve in severely calcified annulus, we can see extravasation related to aortic root rupture. On the right-hand side, we can see a predictive model using a CT information from this particular patient that predicts aortic root rupture, and it actually shows in the area of the left coronary cusp protrusion of the calcium that turns into a yellow and then reddish that indicates the potential risk of aortic root rupture. So one of the most challenging scenario is TAVR in patients with bicuspid aortic valve. And this is related to multiple factors that are commonly seen in patients with bicuspid aortic valve. Those patients have a more frequent extensive annular and cusp calcification and more frequent aortopathy and aortic aneurysm. They also have longer leaflets and therefore a higher risk of coronary occlusion and more frequent need for all of the above parameters for aortic valve predilatation and potential risk of embolization and stroke, and more frequent perivalvular leak, and also more frequent post-deployment post-dilatation to prevent or treat the endoleak, and higher incidence of additional interventions, either at the time of the procedure or later. I would like to share with you several cases with patients that had bicuspid aortic valve, like this patient, a 66-year-old male with bicuspid aortic valve and extensive annular calcification that also extended to the left ventricular outflow tract, as it is shown with red arrows. This patient was sized for 26 millimeter balloon expandable or 29 self-expandable valve for TAVR procedure. And here we can see a simulation on the left-hand side with a balloon expandable valve, on the right side with a self-expandable 29 millimeter valve. And we can see as far as the risk of occlusion of the coronary ostium of the left or right coronary ostium balloon expandable valve, it was a low risk. And using self-expandable valve also, there was a low risk of occlusion of the coronary artery with DLC more than 0.7. Now, as far as the risk of aortic root rupture is concerned, the 26 millimeter balloon expandable valve was at the risk of aortic root and annual rupture, as it is shown with the red zone in the left image. So as far as perivalvular leak is concerned, with 26 millimeter balloon expandable valve, there were no gaps and low risk on the left-hand side. And with a 29 millimeter self-expandable valve, there were large gaps, as we can see with red arrows, therefore a potential significant risk of perivalvular leak. So in overview, as far as this patient with bicuspid aortic valve using DASI simulation, the risk of coronary obstruction with either balloon or self-expandable valve was low. As far as perivalvular leak is concerned, the balloon expandable valve showed no significant gaps and low risk of leak. However, self-expandable 29 millimeter valve showed significant gaps and therefore high risk of perivalvular leak. As far as root rupture is concerned, there was a relatively low risk with balloon self-expandable valve and a higher risk, potential risk of annular rupture with 26 millimeter balloon expandable valve. So as far as procedural outcomes are concerned, we selected this patient to perform a TAVR with a 29 millimeter self-expandable valve because of the fear of potential annular rupture. There were no procedural complications. However, the hospital echo prior to discharge showed mild perivalvular leak that was predicted with DASI simulation. And also at 1 month follow-up, the echocardiogram still showed persistent mild perivalvular leak, again as predicted by DASI simulation. Now here's another case, also with the bicuspid aortic valve. 66-year-old female presented to us with bicuspid aortic valve and pretty extensive calcification, as you can see, of both leaflets. She was sized for 26 millimeter balloon expandable valve and also for 29 millimeter self-expandable valve. As far as coronary obstruction risk is concerned, it was low for both left and right coronary artery with balloon expandable valve, as shown here, and also coronary obstruction risk for 29 millimeter self-expandable valve was low for both left and right coronary artery. As far as perivalvular leak simulation is concerned, with the 26 millimeter balloon expandable valve, there was no significant gaps identified and therefore low risk or no risk for perivalvular leak. However, with a 29 millimeter self-expandable valve, there was a significant gap, as we can see, and a risk for perivalvular leak, at least in 2 locations shown here with red arrows. As far as aortic root rupture risk is concerned, with DASI simulation for 26 millimeter balloon expandable valve, there was a potential risk for annular rupture, but none for self-expanding valve. So in a case overview, in this case number 2, as far as the risk obstruction for coronary obstruction is concerned, it was low risk for both balloon and self-expandable valve. As far as perivalvular leak is concerned, for balloon expandable valve, there was no significant gaps. However, for self-expandable valve, there was significant gaps. As far as root rupture is concerned, balloon expandable valve showed higher stretch, seen potential risk of annular rupture, and for self-expandable, low risk of rupture. As far as procedural overview is concerned, we decided to go ahead and perform TAVR with 26 millimeter balloon expandable valve in this particular case. There were no procedural complications, and the hospital echo did not show any perivalvular leak, and also 1 month echo did not show any perivalvular leak. Now, I would like to share finally with you case number 3 that was probably the most complex case. It's a 72-year-old female status post-coronary artery bypass surgery and placement later of a 19 millimeter trifecta valve, and also status post vein grafts to the right coronary artery and intervention to the right coronary artery. This patient presented with the left main CTO and underwent stenting 10 years prior to this intervention. As far as trifecta valve was concerned, it showed significant stenosis and moderate AI with Vmax of 3.7 and P gradient of 54 millimeters of mercury, with aortic valve area calculated at 0.8 centimeters square. This patient was sized for 20 millimeter balloon expandable valve and 23 millimeter self-expandable valve. As far as Dawson simulation is concerned, related to a coronary osteoobstruction risk, we can see that the distance from the stent placed in the left main to the leaflet was only 1.1 millimeter, and therefore significant potential risk both with self-expandable valve and also with balloon expandable valve. And ratio was considered here to 0.2 as far as predictability for coronary obstruction is concerned. So therefore there was a high potential risk for left coronary artery obstruction with both valves. As far as perivalvular leak is concerned, the risk was low for both balloon and self-expandable valve. So decision was made that there was a too high risk for occlusion of the left main performing TAVR, and therefore this patient was not recommended to undergo TAVR. In summary, computational modeling with simulation can be very valuable in clinical planning for patients undergoing TAVR. Many potential risks that occur during TAVR can be assessed, such as coronary obstruction, perivalvular leaks, thrombosis, and root rupture. This technology can improve our clinical strategy and outcomes, as well as lifelong planning for patients with aortic stenosis that undergo TAVR. Thank you very much for your attention.